junctions with synergy, your volatile and IV anesthetics. And then we'll transition, got a little short little presentation about remifentanil, because I don't think many of you have had any exposure to that. That is a completely different animal. I have not really found many people, I have run into my colleagues who can't articulate how to use it. They just say, well, this is how I do it. And when I casually ask why, they don't really have any base foundations. They usually say something like, well, that's how I should. All right, so without further ado, pharmacology. I adapted this from Dr. McDonough, Bill's history. The difference between opiates and opioids, one's synthetic, one's the original. So you remember the poppy trail from the Asian in the Far East. That's how they began their conquering of the world, and still maintains today. Synthetic opioids today contain a phenylketonuclease nucleus of morphine. But there's important differences between the two of them. There's stereospecific receptors. So you guys have, when I say stereospecific, what are the two kind of isomers that we commonly refer to? Levorotary and dextrorotary, right? And basically that means that if you shine polarized light through it, it kind of bends to the right, to the left. That's the way they're spinning. And they're not always, it's not always the dextro version that's the better, or the levorotary. This tends to kind of met out in the lab testing, which ones are more effective for human beings. There are others that are the opposite for when we use them in animals. There are both presynaptic and postsynaptic sites that these different medications can work effectively at. And outside the CNS, there's research to suggest that there is some peripheral action as well. Okay, so just be aware of that. So much like you guys, have you had a lecture yet on non-depolarizing muscle relaxants yet? So a lot of pharmacology theory has to do with this concept that when we give a drug, right, eventually it's a molecule, right? So the molecule is like a key, and your receptors that do things to your body are like a lock. Okay, so for instance, when we give a drug like succinylcholine or rocuronium, that's an easy one, you know that when you give that, people just they can't move anymore, right? Chemically paralyzed. And the way that works is that the nicotinic receptor junction at muscles, right? If the key, the molecule of the drug, fits perfectly into the receptor site, then you get agonism of that site. Okay, so right now, if I say, all right, right arm, I want you to move up, my brain stem is telling all the right motor nerves down through my brachial plexus all the way down here. Say, all right, contract, right? And naturally, we have at the nicotinic receptor junction molecules of what is it called? Acetylcholine, right? And that just fits into the actin myosin perfectly. We get a contraction of the filaments, and I move. Okay. If we get a molecule that looks similar to it, like succinylcholine, which is two, right? There's two molecules of that. It can also fit into it, but it doesn't fit perfectly. It still accomplishes the same effect. You have no movement for a little bit until it gets metabolized away. The mass effect. Rocuronium fits a little bit less perfectly, and it lasts longer because it's metabolized by the liver. It's not metabolized by non-specific esterases. Okay, so that it lasts 30 minutes or so to get the normal dose. When we talk pain medicines, right? So we have other receptors. They're not nicotinic receptor junctions. They're, you guys, when you do your readings, we have mu1, mu2, all these different receptors that when they are agonized, they produce analgesia. And we have supraspinal, right, and spinal analgesia. And if we are able to put that key into the lock, then it's not possible for brain, right? The brain is what perceives neuronal signals as pain. Right? I don't know, when I get pinched here, I don't know that it's hurting until it travels up to my spinal cord, up to my brain. My brain interprets this pressure, the sensation as pain. You guys, okay? So we've got a plethora of different medications that are available that kind of fit into these different receptors. They, the pharmacologists design these therapies to be able to give at certain doses. They do lots of testing to figure out what the limits are. That's when you guys go into your deep dive in your pharmacology books and says this is the lethal dose, this is the therapeutic index, so on and so forth. These are what create the initial limits. Lots of times they find drugs that are great, but it's not, really convenient to be able to give 60 cc's of a drug to have a therapeutic effect. People want something that fits into like a 5 or 10 cc. doesn't kill the patient by causing them lots of hypotension, so on and so forth. Okay, so that's what we'll kind of talk about today. Opioids activate anti-nociceptive systems, and when we talk about opioids, only the levorotary, so you can give a non-stereospecific combination. It has both dextro and levorotary, but only the levorotary isomer is the one that typically works. Okay? So we're talking about opioids. You guys recognize this list, right? Morphine. Now, I'm going to have a little side discussion about meperidine because it's not really that great for medicine. It's really fallen out of favor. It was originally designed as a vagolytic, and they just happened to find that it also had some analgesic properties. And it also prevented people from shivering when they woke up from anesthesia. So in general, in the anesthesia community, we don't really give that. Fentanyl, alfentanyl, which is really kind of fallen out of favor. So that's an example of a drug where you kind of got to know it for perhaps boards, but you don't really see it given very commonly. Okay? And then, of course, remifentanil. Codeine, you guys recognize these: dextromethorphan, hydromorphone, oxymorphone, methadone, heroin, so on and so forth. Similar structures, right? It's easy to understand why heroin can be so addictive, and then any of the other drugs that are derived from that structure have that same addictive type of problem. Okay? If you guys hang around Dr. McDonough for any period of time, he's very proactive about talking about addiction and, you know, like what are the behaviors that describe addiction, you know, and then this attitude within the community of like, you know, what, we have drug abusers that come in and we have to take care of it. And there is this resistance to give them drugs to treat their pain, right? Because, oh, you're an addict, right? You're going to take, you know, 1,000 mics of fentanyl just to, you know, even touch your pain. So it's your fault for being an addict. And there are people that practice that literally withhold on purpose, or just give, this is what you should do. Okay? So you kind of have to resist that, because our job is not to determine whether you're actually having pain or not. If the patient says they have pain, then our job is to help treat the pain. Okay? That does not mean that we just take a gallon of fentanyl and pour it on like that. We can do some of that, but our job is to use our brains and to try to figure out what's the evidence show is also effective. So blocks using non-opioid analgesics, so on and so forth. All right, I digress. We also have other drugs that are opioid antagonists or agonist antagonists, right? So here's a few of those. Those are sometimes used in off-site areas. We don't commonly use them in the intraoperative area, but you'll find them used, for instance, on the labor deck. They'll try to give some parturient patients. It's a strategy that's been used to try to cause some analgesia, but not any respiratory depression. And these drugs kind of offer that advantage. Unfortunately, if you're a chronic pain patient and you're on a regimen, for instance, of methadone, and then you start titrating on an agonist-antagonist, it actually can increase pain because it's antagonizing the already present therapeutic level of an opioid. Okay, so just bear that in mind. These are the antagonists, the reversals. I've never seen nalmefene, but I have seen naltrexone and naloxone. You guys, as ICU nurses or critical care nurses, you should be familiar with those. In general, the attitude of when you do a case, right, and in the beginning it's going to happen. If you don't test the limits of where a patient is going to, you know, end up not being able to breathe, well, you're not pushing hard enough. You'll never know where the limit is. And there is a kind of like a frowning upon if you have to give Narcan at the end of your case. Well, that's bad. So there's two things. Number one, if at the end of the case I can't get my patient to breathe yet, and the CO2 is like 65, and all of volatile agents off, and they still won't take a breath, is that a narcotic overdose? Now, in the classical sense, like people found down and, you know, not breathing and require resuscitation. But in the anesthesia world, yeah, we gave too much because we didn't accomplish our goal. I cannot take too much. When it's an elective case, for instance. Excuse me. But what's worse? Like, let's say they're breathing 3 times a minute. Really big tidal volumes, like a liter. Right? Could they survive? Maybe. Right? So I think the worst, like the more unfavorable scenario is when you know the patient needs a little bit of Narcan to reverse the opioid effect. and then you purposely don't give it. You don't give it. That's worse. Okay? Now, if all of your cases, or the majority of your cases, require Narcan to get them to breathe, perhaps that is a signal. Most other people don't do that. In fact, it's one of the upcoming quality measures for next year, right? Is what is your utilization rate of reversals for both benzodiazepines and Narcans? And it doesn't mean if you give it one time that's bad, but if you're giving it all the time, perhaps you should take a look at your practice. Right? I had there was in my past I came in to do independent practice at a surgery center where it was routine. Like they gave a lot of benzodiazepine and they gave some narcotics for these like 5-hour-long facelift cases, and then when I came in, they're like, yeah, make sure to give the Narcan at the end. I'm like, what? Like, well, we give that to everybody. I'm like, everybody? I'm like, yeah, we got like huge boxes of it. Everybody gets it. I'm like, that's not normal. I'm like, well, everybody else does it. I'm like, I'm not doing it. Okay, and that's an example. Like, we're in a small little community that they had this perception that would make them safe because they don't have respiratory depression when they're at home. Like, no, there are other bad side effects from giving a reversal that we need to be mindful and aware of. So I think my advice to you is that with a good foundation of how the dosing of different opioids in combination with anesthetics works, you stay within the lines for normal patients, and then you're going to encounter someone that's not normal, right? Like a drug abuser that has extremely high tolerance, okay? And we know to treat them a little bit differently, both with the amount and then the multimodal nature of how we treat in those types of patients. You're supposed to be aware of that and then do the extra work to try to intervene on their behalf. Okay? And then if you miss, you miss. Just don't miss all the time. Okay? So don't be ashamed if at the end of your case you really pushed to get that 2 milligrams of Dilaudid, right? Because you wanted a smooth wake up. I don't know what smooth wake up means, but you don't want them to call for buck. There's lots of different ways to do it, but that's a common way. That it is almost simplified down that what you do is you put your patient to sleep. What we're going to do is we're going to give fentanyl at the beginning because that's short acting. And at the end, we're going to titrate in some Dilaudid, right? We're going to give like 0.5 milligram at a time. We'll just titrate it to respiratory rate. As long as their rate is less than 12, then we can pull the tube and they won't cough or be awake, they'll be comfortable, right? Well, they're going to be narcotized is what they are. So they're just not bothered by you taking a big straw out of their drink. It's like I'm oversimplifying it, but that is literally what will be handed to you and demonstrated to you on a fairly routine basis. But I want you to understand the why for that, okay? All right. mu1, we're going to quickly breeze through these and get some dosing here, but the effect of mu1, analgesia, right? Supraspinal, that's up here in the brain, as well as spinal and the spinal cord, okay? That's why when we do spinals and epidurals, we actually put some opioids. Small dose in the spinal and slightly less small dose in the epidural dose, so that we can have some spinal effect as well as a local anesthetic effect. All right, so what type of agonists, what type of keys work at a mu1 receptor? Endorphins, morphine, other synthetic opioids. The antagonists, right? Fairly straightforward. mu2 also produces analgesia, only in the spinal. The spinal area has no supraspinal effect. It also causes, in addition to analgesia, ventilatory depression, constipation, physical dependence. So ideally, if we had the ideal opioid, we would have one that only agonized mu1 and did not agonize mu2. We haven't found that yet. Okay, the receptors are too intermingled, they're too similar, we can't get that specificity just yet. Right? So when we talk about, there's like a Jekyll and Hyde type of effect going on with these two pairs of receptors, so both mu1 and mu2. And for testing purposes, like your board type exam, you need to remember which one is the bad one, which one is the not as bad one. Okay? Try to help you. Kappa provides also both supraspinal and spinal analgesia, also can cause dysphoria, sedation, diuresis, meiosis, low abuse potential, right? Agonized not by endorphins, but agonized by dynorphins. Okay? Delta, same thing, you guys can read through this. Keplerins are the agonists. Right? And then sigma, dysphoria. So if you had a opioid that had some sigma effect, right, it's not really helping you with pain, but it is helping you have a huge trip, right? That's the effect you're going. All right, So let's get to dosing. My best advice to you is to, when you have a surgery, or a patient having a surgery, try to contextualize in your head. Do you think this will be mildly stimulating, moderately stimulating, severely stimulating? I'll give you maybe some context for that. So if I was having like a little lipoma removed from here, my arm or any part of my body, very small, that's probably mild. It's still going to be uncomfortable, but I'm going to classify that as mild. Okay? If I was having, I don't know, a hernia repair, right, where they're going to pull open some stuff and yank some stuff around, that's probably moderate. If I was going to have my chest cracked open and a sternal saw gone up like this, that's probably severe. That's the high end, right? Does it make sense? I mean, and no method, like you can't like have all the surgeries classified as perfect because every individual patient's perception of pain is also different. So if you get a patient who's very stoic and like I'm in, Iron Man, I'm invincible. No, that doesn't hurt. Your arm just got chopped off. Like merely a flesh wound, right? That guy, maybe he's still experiencing pain, but he's just kind of faking it. Then you have the cultural effects. Different societies express pain differently, right? Classic in the labor and delivery debt, the Latin population. It's theater, is what it is, right? But again, you're not responsible for determining whether it's real or not. That it's real to them, okay? So whatever it is that when you size up your patient, we talk about going to meet your patients ahead of time. You develop a rapport with the patient. You're talking to them. You have a conversation. You're trying to size up. Is this a patient that is very stoic? Is this one that's just like nervous out of their mind and like any little disturbance will cause them to have, a really severe perception of pain? Or is it this is the hard part. You get a patient, you're reading through their medical record and their problem list, and you get to the F word, fibromyalgia. And automatic, you think female, crazy, right? And lots of cats. Just joking. Joking. Please do. She'll hit me again. No, but like we laugh. Why? Because you have probably seen at least one patient that was like and then fit the stereotype. Okay? And then what do we do? Like, oh, they're impossible. Their pain is impossible. Well, it's not our job to say it's impossible to treat. Our job is to find a way to make an impact on their pain. Okay? And our job is to remember that there's more than just fentanyl. There's lots of different interventions that we, as advanced practice nurses, you're not yet, but you will be. So I'm trying to give you the foundation so that you can at least ask about it when you go to clinical. Okay? So that's why multimodal pain, regional anesthesia is really making a resurgence, if you will. So we don't just depend on opioids, right? Even though that's what the primary doctors do. Okay, so low, medium, high. Now I'm going to give you a dose. So if you're going to try to dose your patient for post-operative pain, right? During the anesthetic, they have very little response to pain because they have an anesthetic. And during the anesthetic, you're titrating on different amounts of supplemental analgesia through the use of fentanyl, morphine, Dilaudid, so on and so forth, whatever you choose. But at some point, you have to turn it off. And then you're trying to gauge, is whatever we did to them, when all that's gone, is this mild, moderately, or severe? Okay? So if I were to say that to you, for postoperative analgesia, look at the IV doses. Anywhere from 0.03, that's the ultra low end, so let me make it a little bit easier, 0.05 mg per kg, all the way up to 0.2 mg per kg. IV is the range. But you have to have the right level of stimulation. If you have somebody that has a very mildly stimulating, like a little lipoma removed from their belly, and you give them 0.2 milligrams per kilogram, that's a mismatch, right? You don't have the level of stimulation to cause them to be awake, to breathe, to live, right? And that's where you have oversedation, you have respiratory depression, because you're not matching those two together. So they should be on the low side, okay? And then if you wake up, so you dose them ahead of time, and you don't know yet, but you'll discover through experience that when you try to give too large of a dose of an opioid while a patient is under general anesthesia, and they're spontaneously breathing, like on an LMA, right? They can be very deep under anesthesia, but spontaneously breathing. You'll see the effect of opioids directly. With fentanyl, it happens within a minute. With morphine, it happens within 4 to 7 minutes. With Dilaudid, it happens within 7 to 14 minutes. Okay? You'll see the effect of respiratory depression, and that's kind of your testing bench to see how will they respond afterwards. Okay? And then you know that the duration is different for each of those as well. So the duration, not the half-life, but the duration for fentanyl is about 30 minutes. Right? Morphine, you get into the 2 to 4 hour sections. Dilaudid a little bit longer than that. So that's 4 to 6 hours, depending on the patient. So if you had to err on anything, you give it earlier, not later at the end, so you can see what the effect is. So let's say we're doing a gallbladder, cholecystectomy. We'll call that moderate, right? Because it's not a laparoscopic case, it's a mini laparotomy, so it's an open gallbladder. Let's say they're doing that, we'll call that moderate. So if I had to go from 0.05 to 0.2 milligrams per kilogram for morphine, then 0.05 is the low, 0.1 is the medium, and 0.2 is severe. So if I weigh 70 kilograms, how much morphine should I have on board when it's time to wake up? You can use calculators. That's what, so we give you the range, 0.05, 0.1, and 0.2, low, medium, high. So if I'm having my open gallbladder today, and I'm asleep, and they're in the middle of doing the gallbladder, how much morphine should you give me, according to our little 7 milligrams, okay? If you give me, if I'm asleep, I'm paralyzed, you can't wait to the very end, because in a private hospital, they'll close that thing in about 4 minutes. And then you give, and then you cross your fingers, and then you hope that I breathe. So ideally what you do is you work in, 2, 2, 2, and you wait. Your final ending dose when I get to the recovery room should be around 7 milligrams. So maybe what you do, if you're working at a very fast place, like a Baptist or St. Vincent's, you just give 2 milligrams. Or 4, the most to me. And you wait till I wake up and you say, that's my wife, how do you feel? I'm like, I still hurt. I'm like, oh, here's the last 3. And then you leave. And you let the packing nurse take care of the rest of it. Your job is to just try to not leave me in agonizing, grinding pain. Okay? Not ideally, in an ideal world, we want to be absolutely, pain-free. But pain has some function, right? Like when the pan is hot, I feel that I'm going to get burned up, pull my hand away. Right? So there is a protective function for pain. But we're trying to reduce it so that it's not agonizingly painful. Okay? Does that make sense? So you look at the low, medium, right, severe, or whatever, mild, moderate, severe, however you want to say that. Divide your dose range into a low, moderate, severe. And then just try to imagine what's the final plasma level that we want to end up in. So 0.05, 0.1, or 0.2 for morphine. It becomes easy because you guys know morphine equivalent doses. Do you not? So when I say 10 milligrams of morphine, what's the equivalent dose for Dilaudid? Morphine equivalent dose. It's like, if I say 10 milligrams of morphine, it's like 1.7 milligrams of Dilaudid. We round to 2, honestly. So if I say 10 milligrams of morphine, we say 2 milligrams of Dilaudid. That's the thing. So what I do in my head, and then so if I was giving 5 milligrams, it'd be like 1 milligram of Dilaudid, roughly. You can't do all the decimals all the time because you drive yourself crazy. On top of that, you can't actually draw up 1.35 milligrams of Dilaudid. So we've got to be practical at some point. I'm trying to give you the practical so that you can actually do this inside the operating room when you get there. Okay? So let's say we're back in the operating room again. I'm having my second gallbladder out because they missed it the first time. They're doing it open again. Right? We're going to call it's moderate. But you're with a new preceptor this time. It's like, you know what? I'm a Dilaudid. I just love Dilaudid. So we're going to give it Dilaudid. All right. So if moderate. Like, think about morphine. We said it would be about 7 milligrams of morphine, right? So how much Dilaudid should you give? So if we said 5 milligrams of morphine would be like 1 milligram of Dilaudid. 10 milligrams of morphine would be like 2 milligrams of Dilaudid, right? Roughly. So how much Dilaudid? 1.5. Anywhere between 1 and 1.5 would probably do you just about right, or do me. Just about right. Okay? Let's talk about fentanyl. So if we're doing fentanyl, 10 milligrams of morphine equivalent dose for fentanyl is roughly is, which is a little low. Equi-analgesic dose is close to 100 mics of fentanyl. Okay, that's easier, right? So if we want to give 7 milligrams of morphine, it would be about 75 mics of fentanyl. Right? The problem is you got to give it right close to when I wake up, so I can experience the effects of that analgesia when I'm actually waking up. Right? If you give it too early, at the beginning of the case, the duration of action is 30 minutes. The case takes 30 minutes. When I wake up, where's the fentanyl? It's not working. Okay? And again, you guys will discover what happens when you'll be doing an LMA case for, I don't know, it doesn't matter what the procedure is. They're breathing spontaneously, they're breathing 18 times a minute. Your preceptor will say, how much fentanyl do you want to give? And you want to reduce the respiratory rate and have an analgesia level. And you'll say, I want to give 50 mics. And they'll be like, okay. And you go to give it, and then you give 50 mics of fentanyl, which is not a lot for a 70 kilogram person by our little schedule there, and then they go apneic. And then you discover, like, oh, evidently, under general anesthesia, I can't give more than 20 to 25 at a time if I don't want to knock out the respirator. Okay? So this is what you learn in the very first year or so. You're trying to figure out this titration of narcotics while they're spontaneously ventilating. And it's easiest learned on an LMA type case because they're already spontaneously breathing. When you have somebody that is mechanically ventilated and intubated, it's a little bit more complicated because they're paralyzed. So of course they cannot breathe, and there's no way for you to titrate it. Okay? And then you use your experience at places like U of Health, or the General Hospital, where the cases take hours, hours, and hours. You get plenty of time near the end because the closure takes an hour. So they don't need muscle relaxant for that part. You reverse it, you use Gamadex, do whatever. Now, they're still very deep under volatile anesthesia, or they have an IV propofol drip, and they're very deep under anesthesia. And you can make them breathe spontaneously on an endotracheal tube. It seems like counterintuitive. They cannot be awake. They can be totally asleep under a volatile agent, and they can breathe spontaneously with an endotracheal tube inside their trachea. Okay? And then guess what you can do? You can titrate on some narcotics. Same methodology, right? Another thing that gets really complicated is that if you're having a laparoscopic procedure, yes, it is uncomfortable and painful. You have the CO2 pneumoperitoneum. They're like in steep, Trendelenburg or reverse Trendelenburg, all these things. Got 5 trocars in, but at the end of the case, guess what they do? They take them all out, and all you got is that's it. And that is actually not quite as painful at all. So if you're tossing tons of narcotics during the case to treat their stimulation at that moment, and you give them a ton, like a Dilaudid, well then after they remove all the stimulation, you have that mismatch. So you're really trying to think about where do I want to be an hour from now, right? And with Dilaudid, for instance, you want to say, where do I want to be 2 hours from now, so I can be safe. So if you gun it and you go all in, right? And you're like, yeah, I want a nice high narcotic wake up, right? You'll think the blood pressure will be fine. They will even spontaneously breathe while all the stuff is going on. But then when they remove the stimulation, you have this huge, very high plasma level of an opioid and no stimulation to help them remember to, hey, you're still on this planet. You need to take a little breath every now and again. Or you're telling them to take a breath. It's not that they can't breathe. They just don't know it's time to breathe. I experienced this. I got the video. I went through my my box. I have a box of old VHS tapes. They had these 8mm tapes, high 8 tapes. I had no idea. I had no players for them, so I sent them to this company called Legacy Box. They've got lots of technicians there. They encode it and they send it back on a USB stick. And I saw the video of what happened when I graduated from school, went to Colorado to practice snowboarding for my career. And I dislocated my shoulder. I didn't have any insurance. I refused to go to the ER. I had my buddy put his foot into my armpit, yank on it a few times. I'm screaming as I'm biting on a sock. And then finally I gave in. All right, I guess I got to go to the ER. It's very amusing to watch me try to get dressed with a dislocated shoulder. I asked him for help. He said no. Go there. They give me 4 milligrams of midazolam and 250 mics of fentanyl. All at once. And I schooled it. I told the nurse, I know what I'm doing. I do not drink alcohol. I don't do drugs. I am a lightweight. Go get the ambu bag right now because the onset time for fentanyl is about a minute, and I'm going to be yapping because the synergistic effect of potassium. As I'm talking, like all the pain in my shoulder, I was like, "Ooh!" On video, try to edit it so you can maybe watch it. But my point is, when the level of stimulation matches the level of narcotic, right? The analgesia level is right. I will still breathe. Now, I also experienced something else that this drive to breathe went away because my saturation was 86%, and I'm like shoving the nasal cannula, trying to breathe, but I'm not breathing as much as I should. And my friend is, of course, just laughing at me as he films me. I'm like, could you maybe switch me to a face mask or a non-rebreather? Once the brain cells, once this stuff. So, anyways, the drive to breathe. It's not that they can't breathe; they just don't know they need to breathe, right? Okay. Make sense?
I have a question.
Okay. Perhaps an answer.
Whenever we did the calculation for how much morphine we would give, we used the post-op?
Yes. So intra-op analgesia, that's something totally different. Because if you went to like on a normal, again, these are all dose ranges for normal people. They react normally. You have everyone that's outside the bell curve may react differently. It can be overly sensitive or not sensitive at all. So intra-op analgesia, they lower the dose because the effect of vasodilation, especially with morphine, not so much with Dilaudid, and it can happen with fentanyl as well, is exaggerated because you have synergy with your volatile agent. So if you were to give a huge dose of Dilaudid all at once, they would become inconveniently hypotensive. How about I say it that way? You can fix it, but why? Just wait a little bit, and then when that wears off a little bit, you can work the rest of it. Does that make sense?
Yes, so you said that, so what's listed there, the intra-op is higher than what our post-op would be.
Because, and I have to give you context for this, is the 1 milligram per kilogram. So if I am 70 kilograms, and you gave me 70 milligrams of morphine, that is the anesthetic.
Oh, if you were using it for the whole thing. Okay.
That's what in the olden days, right? In the like McDonough days when he was starting, they would actually do total narcotic anesthesia for hearts. They would literally push 60 cc's of fentanyl, right, or 140 milligrams of a really big guy of morphine. That's it. Bye bye. And then they would give 10 milligrams of midazolam or Valium. And then they would give this drug called Pabulon, which is a long-acting muscle relaxant. So you'd be chemically paralyzed. You'd be completely pain-free for the next day, no matter what we did to you. And if you happened to be awake while they were on bypass, you probably wouldn't remember it. That was the technique.
And then they didn't get out of bed for 3 days?
Probably. And that was acceptable at the time. Now we're like trying to extubate them on the table, get them up that afternoon, so on and so forth. So times have changed, right? But that I need to give you context for the insanely high doses, right? If you were to give fentanyl, right, and do that, it's almost like, it's ridiculous. It's 10, 20, 30 mics of fentanyl per kilo. And you just give it, the whole thing. It's a weird feeling. The pyridine I crossed out because we don't really use it for analgesia. I have to show you, but don't really pay much attention to it. Fentanyl. Look at the therapeutic range. It's low volume, right? 150 mics per kilo of fentanyl. The maximum therapeutic dose. We're trying to give. Now I have to teach you for fentanyl the mild, moderate, and severe range. Okay. Please remember this. This will help you. Okay. So if you have a patient having a little lipoma removed from their belt, I'm using the same examples, right? 1 to 3 mics per kilo would be considered a mild dose. I weigh 70 kilograms. You can give me anywhere from 70 to 210, right? If you're giving me my gallbladder, open gallbladder, that's moderate, right? It could be anywhere from, guess what, 4 to 6. If it's severe, 7 to 10, right? So if you're going to try to bump me for the sternal saw, just draw up 700 mics of fentanyl, punch it, I'll be good. Okay, so if I'm having my gallbladder out, there's no need to give me any more than 4 to 6. I usually start on the low end and see how the patient does. Because again, we're not machines. We human beings are, biodynamic type, devices. So, but that gives you your reference point. Okay, that's why sometimes it's invariably this will happen. It's your first, second, third, maybe first month. All right, and I hand you all the syringes. You're not used to this. And I'm like, all right, so this thing, just the syringes are there. You know the doses, so go ahead. And your mind freezes. And like, I've only seen them just push a syringe of everything, and then we go. Right? This is not what you trained to do. Okay. Then we get to you put the lidocaine in. You're like, I don't want you to feel the stinging. And you push the lidocaine in, and you go to the propofol, and then right when you hook up the syringe to the 3-way stopcock, I ask this question. So how much fentanyl do you want to give? And you're like, shit. I would have thought that. Then the patient is already like on its way down, and now you have to think, well, how am I going to switch syringes and do this, and sucks this next, right? And then it messes up your whole thing. Right? And I don't do that on purpose. For fun, it's an exercise that makes you think about, well, it takes 2 to 3 minutes for the peak effect, so I really should have given the fentanyl before I even gave light. Right? Just think about it. Then the next time, right? The next case. Like, aha, I won't forget the fentanyl. That's great. How much are you going to give? And you're like, 50 mics? And I'll say, well, what is the mildly stimulating dose range supposed to be? And you will somehow recall 1 to 3. Like, your patient weighs 100 kilos. Do you think that that's an appropriate dose? Right? It's role playing, right? I'm trying to help you think through it. But if you don't have some sort of framework with which to begin to make a decision, it's all guesswork. I don't want you to guess. Okay? Does that kind of make sense? If you have a 100-kilo person, you're going to intubate them. That's at least mildly stimulating when you put them a laryngoscope in and you hang them off of a blade for 30 seconds. For some of you, that will be moderately stimulating, and you need to up the dose. Okay? Make sense? So 1 to 3, 4 to 6, 7 to 10. Fun. Sufentanil. You guys will run across this. This is super fentanyl, not to be confused with carfentanil, making its rounds in the synthetic party drug market. Okay, so sufentanil, for easy math in our heads, we say that sufentanil is 10 times as powerful as fentanyl. But that is a lie. If you read consulting, you'll see that it's 4 to 7 times as potent as fentanyl. Okay, but for easy math, you'll learn fentanyl dosing first, and then when you have the opportunity to dose for sufentanil, you will, that's the multiplier that you should use. Okay? So, for instance, if I require 100 mics of fentanyl for my intubation, right? And then I say, no, we're going to use sufentanil. For easy math, you would say, what's the dose for sufentanil? 10 mics. But in reality, divided by 10. So in reality, though, it's only 4 to 7. Does that make sense? Mm-hmm. So dividing by 10 still underdoses a little bit. So you have the reason why they do that is you have some leeway. You can go a little bit more and still be safe. Okay? Practically, yeah. The dose for when you're going to, and it's best designed when you guys read through it, the pharmacokinetics make it much more ideal as an infusion of an analgesic than fentanyl. Okay? Because as soon as you turn it off, even if it's in 4 or 6 hours, the tail of the infusion ends in 45 minutes. So you get a very nice ending of your anesthetic. They still have analgesia, and they can still breathe. Okay, fentanyl, if you were to give, I'm sure you guys realize that you need a drug holiday if you're giving a fentanyl infusion for days and days and days, then they take forever to actually come around. Okay, that doesn't happen with sufentanil because of its metabolism pathway. It's slightly different, and it's the tail of its infusion lasts only about 45 minutes. Okay, that means that you have to fast forward in your brain. Like when they're closing, you have to say 45 minutes from now, or maybe an hour, I need to press pause. Okay? The dose, when you bolus it, it only works if you give a bolus and then begin the infusion, is anywhere from 0.25 to 1 mics per kilo. Okay? So, Again, let's say, we'll do easy math. If I'm 100 kilograms and you're going to put me to sleep and use sufentanil as your analgesia for the case, right? So I give you all the drugs. Instead of fentanyl, you have sufentanil now. Now let's say I weigh 100 kilos. I don't. But you're going to dose me for that. How many, if the induction dose is 1/4 to 1 microkilo, then the minimum amount you need to give me is 25 mics. Okay? And it doesn't matter whether it's diluted or whether it's the high testosterone on the vial. You give me 25 mics minimum. All right? You'll learn in the future because one of the side effects of giving a large amount of synthetic opioid all at once is chest wall rigidity, which can be quickly solved by giving muscle relaxant, as long as you can ventilate. You can't figure out whether you can ventilate or not because my chest walls are open. Dicey situation. Okay? So usually what people do with sufentanil is they give between 5 to 10 mics every couple minutes until you've given your bolus dose. Then you begin your induction. One of the other you guys please remember this also, if you ever get the chance to use sufentanil, you do not ever give sufentanil in the pre-op holding area and then also give the midazolam. One of the main differences between fentanyl and sufentanil is sufentanil has a profound respiratory depressant effect. So if they're in a lot of pain, you can titrate on 5 or 10 mics of sufentanil only. But you should never give midazolam in the pre-op holding area and sufentanil, or the potentiation, the synergy between it is so much stronger than with fentanyl. So treat them differently in this effect. If we're together and we're using sufentanil that day, we will give it. But we will give it in the operating room when we arrive. In case they become active, I have an easy way to begin with sleep. I would never do that in the pre-op holding area. Even if I was right outside, like the OR is right across the hallway, I don't want to be in that situation. Okay? Question?
You never give it with first time in pre-op, or you don't give it in pre-op ever? Even though
I have given it on occasion to patients who are in extreme pain, who've had opioid tolerance. That's one of the reasons why we do it. So they've seen, Norco, they've seen Roxysets, all this other stuff. They've never seen sufentanil before. So they tend to have better analgesic effect with sufentanil. It's something new. Okay? But if I were to give it in the holding area, I would give 5, let's say there's 70 kilograms, I would give 5 to 10 mics at a time and work my way up every couple minutes until I got around 1/4 microkilo. And I would never give that and then not have them on a pulse ox, not have oxygen supplementing, and not let the nurse know that I didn't give just fentanyl, I gave sufentanil, so they need to quit Facebooking and they need to you're watching. Right? Because it could be, they'll just go after it, and then they're down the juice. And then someone will be yelling at you, why did you give the sufentanil holding? Okay, and the likelihood of that happening is far more likely if you happen to give midazolam at the same time. You also have to remember that if it came from the floor, if they've been receiving benzodiazepines, you should not give them sufentanil in the pre-op holding area, ever. Okay, so I would just approach it with kid gloves, because it's I cannot emphasize how powerful the restorative is. Okay, so then we go to the room, you work in 5, 5, 5, 5, you get up to your 1/4 mic per kilo. Let's say they have tons of opioid tolerance, maybe you might be able to get up to 1/2 mic per kilo. Okay, I've never really, except on one occasion, when an anesthesiologist wanted to prove something to me, given 1 mic per kilo. He gave it, intubated, then left, and then I had an hour and a half of profound hypotension that I dealt with. It's fine, right? But it was unnecessary. Okay. Immediately after giving the induction, you have to begin the infusion. The infusion range, right, is 0.005 mics per kilo per minute, up to a maximum of 0.05 mics per kilo per minute. Do not confuse those numbers with mics per kilo per hour. I don't care which, you can convert them over to mics per kilo per hour if you want to. Most people use mics per kilo per minute as that's what they have in their head, so they set the pumps up that way. There are a few people who like mics per kilo per hour. It's all the same. But the original dose range is 0.005 to 0.05 mics per kilo per minute. Now you need a range, right? We need our mild, moderate, severe. Right? So 0.005 is the minimum therapeutic dose, mics per kilo per minute. All the way up to about 0.015 mics per kilo per minute. That's the range for mild, right? And mild is like a different context because we wouldn't even be using sufentanil unless it's like a weird patient who had opioid tolerance, so on and so forth. If we're in a moderately stimulating procedure, we'd be anywhere from 0.015 to 0.025 mics per kilo per minute. And anything more than that, we'll consider that severely stimulating or off the charts. I can count on one hand the amount of times I've ever made it to 0.03 mics per kilo per minute or above. It's ridiculous. Okay? And the reason why sufentanil is preferred on some of these like neurospine cases, for instance, cranies, so on and so forth, is the amount of analgesia is different than more intense analgesia. Okay? They can be completely pain-free. It's just, it's hard to describe other than the fact that the level of analgesia is more profound with sufentanil than it is with regular fentanyl. Yes, sir.
So again, when you're giving this is all you're giving. You're not giving any Versed whatsoever.
Okay, in the OR, if you want to give some Versed with your sufentanil, go ahead. Just be aware that they'll probably go after it, and you need to be able to bag them. Okay. Yes.
Just want to clarify the range for the mild. You said it was 0.005.
0.005.
0.005 to 0.015.
Correct. Okay. And you know, sometimes I've done on cases where at the very end they say, oh, you got to cut it off 45 minutes before. That's the other part of an infusion of sufentanil. You have to make sure it's off. And if you cut it off too early, guess what? They wake up writhing in pain because none of the sufentanil is left. So the timing is really the hardest part about using sufentanil. People who, if you're with a preceptor, they say, I don't really like doing it because there's too much variability. So if you're working at a place that has a residency, and the closure could be anywhere from 30 minutes to an hour, and you have no idea, it's not really the best choice because you can't predict when the end will be to. Okay? Which is why some people just don't turn it off at all, and they lower it to just like a slightly subtherapeutic dose, and then wake them up on the sufentanil infusion. Okay? Advanced stuff for later. I'm just trying to teach you mild, moderate, severe for fentanyl, morphine, and so on and so forth. Okay? Make sense? Yes. How fentanyl, you can read the doses, but I've yet it's fallen out of so much favor, I wouldn't focus too much time or attention on that. Remifentanil, right? If you know anything about, have anybody used remifentanil so far, or been in a case that have one? No? Okay. So remifentanil is like the new kid on the block as opioids go. And I switch into this one. Oh wait, well, let yourself just telling the story. All right, so remifentanil is totally different, right? And it's very popular for doing total intravenous anesthesia because if you were to give propofol, propofol works on what receptor? GABA. Okay, so does GABA agonization have any analgesia? Did you see that anywhere in the last presentation? No, no analgesia, right? But it just causes hypnosis, right? You're not awake. So you can't give a total propofol anesthetic and expect to have any sort of analgesia. So you can use fentanyl, morphine, Dilaudid, sufentanil along with propofol, and you'll have your analgesia complex. That's fine. But there are some cases that are intensely stimulating, and then you want to wake up really fast enough to be spontaneously breathing. A great example, for instance, is when you have a exam under anesthesia of your vocal cords, when they're going to hang you off of a massive laryngoscope blade for an hour. And it's very stimulating, right? Your poor little epiglottis is just smashed by the weight of your upper thorax, your neck, and your head, right? And then you literally, when you see it done the first time, you're like, oh good God. The sore throat will never go away. So it's intensely stimulating, but as soon as they pull it out, it's like a laparoscopic case, there's no more stimulation. Okay, so you need a ton of analgesia, and you need that effect to go away within minutes. That is what remifentanil is, the designer analgesic that came onto the scene about, I believe, around 25 years ago. You know, if you look at, just to put it in perspective, right, fentanyl was first synthesized in 1960, right? Super strong, it's potent compared to morphine, versatile. We use it a lot. Fentanyl alone is the most widely used synthetic opioid in the planet, right? 1.7 metric tons, 1,700 kilograms per day, right? But the invention of fentanyl led to these other analogs: sufentanil, remifentanil, alfentanil, okay? I'm going to skip over this. All is what you need to know. It's classified as an ultra short acting synthetic opioid. I'm telling you, it is on in a minute. You put it on, it's on in a minute. It's gone in 4 to 7 minutes. Right, so you have a very powerful analgesic action. You have agonization of mu1 and mu2. mu2 is the bad one, right? Causes respiratory depression. Very potent respiratory depressant if you give the full dose. Okay. Wrap it on, wrap it off. Non-organ dependent elimination. This is how it is definitively different than every other opioid we use. Okay? So if they have liver failure, kidney problems, don't matter. Right? Clearance is several times more rapid than hepatic flow. It's 70% protein bound. So some of our other drugs that we use commonly, like propofol, for instance, they're like 90% protein bound. So if you have any protein abnormalities, there's a huge swing in effect. With some of our other drugs, it's not as exaggerated with remifentanil. Okay? It's not significantly sequestered in the lungs like fentanyl does. They use this concept when you do your readings that fentanyl kind of hides in the lung tissue, right? It's not in the lung tissue. Does that work for supraspinal and spinal agonization of the receptors? No, but it's there, and then it kind of leaks out, and that's what causes its continued effect of sedation afterwards when you turn it off. Okay. Remifentanil, you can use it in kids, adults. If they've got renal impairment, it doesn't really clinically significantly effective at all. What I want you to look at is these doses here. So if you were to give a bolus dose, this blue line, yellow line, this is the plasma concentration, right, in nanograms per milliliter, and then they just keep it at whatever the infusion. You have to give it as an infusion. You cannot give it as a bolus. Go, 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 go. Look how many minutes this is, right? 15, here's an hour, 2 hours. This is the point where they shut it off, right? Within 20 minutes, there's no detectable plasma level at all. Okay? That's important to understand. The tails for like fentanyl go way, way up, and then they like arc way over here like this. Sufentanil is a little bit more forgiving. It's a 45-minute tail. Remifentanil falls like a rock as soon as you turn it off. Okay? Very dangerous to not have it. Like if you think it's running and it's not running, and you're depending on it to run, like when the IV infiltrates and you're doing this big case and the patient's in pins, for instance, not good. Okay, so you really have to pay very close attention when we're using these types of these agents as adjuncts. Okay, ideal body weight is considered best for dosing. I write that here. But if you have someone who's opioid tolerant, it's all out the window. You just keep going up. Keep going up. Okay? It is slightly, in the literature when you read through it, the tachyphylaxis, so the resistance over long periods of time, tends to be more prominent with remifentanil than sufentanil or regular fentanyl. Don't get hung up on that. Just realize that sometimes it's normal to have to give more of a dose to someone who's received it several times. Okay? Thankfully, they always make more. Let's see. What I want to show you is how you dose it. All right. I get all this straight. You can read this in the product insert. It's not rocket science. Okay. If you're going to induce a patient with remifentanil, you have to have the pump ready, you have to have the infusion ready, and everything's connected and ready to go. So you give the first bolus dose is 0.5 to 1 microkilo. Right. That's it. So, if that's the range, 0.5 is the mild, 0.75 is the medium, and 1 is the severe, right? So if they're going to have a long 1-minute laryngoscopy, which is your first day, I give 1. If I'm doing it, I might give 0.5, right? All right, so you can give 0.5 to 1 microkilo over a minute. The reality is, again, product insert says this. In reality, we just push it. Okay, you begin the infusion right after you do that. Okay, maintenance with GA, right? Typical dosing is 0.05 to 0.2 mics per kilo per minute. Okay, so the minimum therapeutic dose, the lowest your pump should ever be set for a TIVA infusion is 0.05 mics per kilo per minute. Okay, so that's mild. Medium would be 0.1 mics per kilo per minute. Severe would be above like 0.2 mics per kilo per minute. That's the range. You can go as high, if you're reading the insert, up as high as 0.5 mics per kilo per minute. But there's a problem with giving that much. Your bag runs out in about 20 minutes. You're just like making bag after bag, so it's not ideal for, if they're that tolerant, we need to be looking at a different intervention, sufentanil, for instance. Okay, most patients anywhere from 0.05 to 0.2, 0.25 mics per kilo per minute. That's the normal range. Okay, and it's used in different manners. There are some people who like to match the level of propofol. So if you go up with propofol, you go up with the remifentanil at the same rate. The reason why we do that, if you're at 100 mics per kilo per minute of propofol, you should be at 0.1 mic per kilo per minute of remifentanil, right? So they synergistically work together. In that case where I was talking to you about the exam under anesthesia with the direct laryngoscopy, that's an example where you might mismatch them. You give only 100 mics per kilo per minute of propofol, you do 0.2 mics per kilo per minute of remifentanil. So you have this intense, strong analgesia, the minimum amount necessary to keep them unconscious. They have no reason to become conscious because they're so, their stimulation is so abated because of the massive amount of analgesia. Okay? So that's the dosing, right? And if you ever need a bolus, like let's say they look like they're responding, you give another mic per kilo, right? Or another 0.5 mics per kilo. And then you should always increase the dose of your infusion. So if you're at 0.1, you go to like 0.125. I just do like quarter mic per kilo increments up or down. Okay, and as soon as you make it, in 5 minutes, the plasma level's been reset. Right? It's very, very fast, up and down, up and down. Okay. There we go. I think I kind of gave this to you. Oh, there's an even higher class. I call it ridiculous class of 2 mics per kilo per minute. That's for cardiac anesthesia. Just pure, nothing else. You give only that. Okay. All right. So the wake up. This is the hardest part. So you guys saw the graph before. It like drops off like a steep cliff. The reality is, it says it's gone in 4 to 7 minutes, but they lie. They lie. They lie. They lie. Okay. If you're at the low dose range, right, 0.05 to 0.1 mics per kilo per minute, you shut that thing off. The analgesia will be gone. Nothing left in 5 to 10 minutes. Okay. If you're at the moderate, right, 0.1 to 0.2 mics per kilo per minute, it's probably about 10 to 15 minutes. Anything higher than that, right, 0.2 to 0.3 mics per kilo per minute, it's probably closer to 10 to 20 minutes. That's the reality. So they cannot reach. So this is the crazy thing about it. You're going to learn how when you have a patient on LMA, they're spontaneously breathing, you're like kind of working in the long-acting morphine or the Dilaudid or even the fentanyl. You have to give small little doses so you don't knock out the respiratory drive. There is no possible way to do that with remifentanil because the amount of respiratory depression when you're giving an infusion is so profound, they'll never breathe. And it comes off so fast that you cannot possibly give whatever next analgesic in time before it totally wears off. Does that make sense? Like if it's like, oh, I'm totally comfortable, you got plenty of plasma level, you turn it off, it goes, gone. And essentially, like let's pretend they had an X-lap. They had their belly, sliced open, here, rotor-rooted around, everything's sewed back together. Imagine you just woke up and then you realize all that got done. You have absolutely no pain medicine at all. Right? Not fun. Leads to this occurrence of something called hyperalgesia. Then you can't even get it. There's no amount of normal analgesic dosage for anything else, fentanyl, morphine, Dilaudid, will ever touch it. Right? So people shy away from using it because they had bad experience doing it, but that really leads from them inappropriately dosing their transitional analgesic. Okay? So you have to have a plan for what's going to be after. If you're going to use remifentanil, you can't just wind it down and say, all right, we're done. Okay? Now for something like that direct visual laryngoscopy exam under anesthesia, you need the Remi super high levels, that's fine. When you turn it off, you can give them IV Tylenol at the very beginning of the case. Now when the remifentanil's away, like how long does does Tylenol last? 4 to 6 hours, right? So that's okay. You have something in the background to help with pain afterwards. Okay? So you have to remember the transitional analgesia for postoperative pain control. Okay? Yes.
Could you do it the other way where you use something else for like the baseline and then use this at like remifentanil as a bolus?
You could, but it's kind of backwards. So if you think about that, let's say very beginning, you know it's gonna be a 4-hour case. You give like 3 milligrams of Dilaudid at the beginning, and you run Remi behind it. You already have tons of analgesia there already, and you have no ability to modulate. So during the procedure, there are some parts of the procedure that are very stimulating and then not so stimulating. So you have that ability to titrate your analgesia level with remifentanil. You do not have that with Dilaudid. So one of the things you do on these longer cases that are using remifentanil is you're kind of exploring your patient and their response. And that kind of gives you an idea of what you think they're going to need afterwards. So you're trying to give your longer acting transitional analgesic to cover you afterwards at an appropriate level. Does that make sense?
Yeah, I was just thinking like if you did like a smaller dose of Dilaudid through the whole case and then use the remifentanil just for those super stimulating times, like, okay, I know that this is about to happen.
You can.
It'll be gone.
You absolutely can, but it really messes, then you have no real visibility. You don't know, is the Remi working it or is it the Dilaudid? It's better to just have one thing and you can understand the effects of those 2 agents first. Does that make sense? It's not me, you can certainly do it. You just have no idea what you're going to end up with at the end. Is what most people would say. Okay? So I think I said this already, you cannot get the patient breathing while Remi is infusing. You're going to see this in your clinical sites where they're going to have a long case, then you'll hear this rate, we're going to get them back breathing. Raise the CO2, patient starts breathing, they're still asleep, right, with the volatile agent, and they kind of work in. They love to say, we're going to work in some morphine, work in some Dilaudid, right? And yeah, that's what they do. And they're just titrating it to respiratory rate, and we associate indirectly a lower respiratory rate between 8 and 12 to be enough narcotized that they shouldn't be bothered much. They should have a pretty low pain score when they get PACU. That's the end goal. You cannot, it's impossible to do that with remifentanil. Conversely, right, so in addition, I mean, you cannot turn it off, wait for them to start breathing in a minute, and then give them a ton of morphine because it'll take 7 minutes for it to work. They will still have this window of 5 minutes where they have a hyperalgesic response. And the morphine that should have worked, had you stayed in front of the pain, will not work. Then you give them more, then they go apneic, then you reintubate the PACU. Okay? So, what are we supposed to do? Right? You can give a non-steroidal. Don't forget you can give Toradol and acetaminophen, IV acetaminophen. It's good for mild to moderate pain afterwards. Right? So we can use the Remi to modulate in the middle of the case, and we can plan from the very beginning, or in the middle of the case, we dose their mild to moderate analgesic dose of a non-opioid analgesic in the middle of the case, and they will, when you take the Remi away, guess what's left? Toradol and Tylenol run at full tilt. Okay? That's perfectly acceptable. Okay? Oh, sorry. If you're going to use Dilaudid, right? Again, you need some basic experience to understand this, but Dilaudid, it begins to work in about 4 to 7 minutes, and it peaks in the, I don't know, 12 to 15 minute range, and it lasts for up to 6 hours. Okay? So if you had to err on the side of caution, you'd want to give it earlier rather than later. Okay? Unless you figure out the dose, let's say we're having, I don't know, an X-lap, and we're going to call that moderately stimulating. So you're planning on giving me, 15 milligrams of morphine or whatever, 2.5 milligrams of Dilaudid. Then halfway into the case, when there's still 2 hours left, you can dose the full dose of Dilaudid, right? And then wait at the end of the case, and whatever. Again, then you're using your method where you're kind of supplementing the Dilaudid with your Remi as needed. And when it's done, you just turn off the remifentanil. And then what's left? When the plasma level of Remi goes away, you're left with a therapeutic level of Dilaudid or morphine. Okay? So this is really important here, and I don't think you really kind of connect the dots now, but you'll come back to this in about 6 months, and if you use Remi a little bit, it's important to look at this. So if you look, right, pretend you gave like a bolus dose of remifentanil right here, right? Up, down, right? Gone in 7 to 10 minutes. Okay? But you start your infusion right here. It goes up, and I don't care what you set it at. But this is the pain, this is the level, the plasma level at which above respiration cannot occur, and below respiration can occur. Okay, it's just, right, agonizing the receptors and you have no drive to breathe. Okay, so this is good. We have analgesia. We're also not breathing, not breathing, not breathing, not breathing. And I already showed you what happened when you turn it off. It drops like a rock. So let's say this is the time that we want to both wake up and extubate and breathe. Right? Just pretend we know this is what's going to happen. I'm going to shut this off here. I have to work backwards. You mainly have 3 opioid options, right? Fentanyl, morphine, and Dilaudid. Those are the common ones. Right? And you know that fentanyl works very quickly. Onset is within a minute or 2. Peak onset is around 4 to 7 minutes, and duration lasts about 30 minutes. So you will also have learned that when you give 50 or 100 bites of fentanyl to someone spontaneous breathing, they don't breathe for about 10 to 15 minutes. Right? So 30 minutes before, you get it ready, and then right at the 15-minute mark before, so they're closing, you give the full dose of fentanyl, full thing. You're not going to be able to work it in. So let's say I weigh 70 kilograms and I'm having like my gallbladder thing. Let's say you use Remy on this and they're beginning to close. You would give me 75 to 100 bites of fentanyl right here, right at the 15-minute mark, right? You turn off the Remy when they're stapling, and then it goes away completely. And what am I left with? A therapeutic plasma level of fentanyl. Okay, timing is everything on this, right? Which you will have no experience being able to make a decision on this at the beginning. But I have to give you a framework when you get to that point of how to start making these decisions. So what about morphine? Morphine starts working in about 4 to 7 minutes, right? Peak onset is close to 10 minutes, and it lasts for, I don't know, variable, 2 to 4 hours, okay? So you will discover this also if you're working in morphine. If you were to give me 0.1 milligrams per kilogram, right, which is a normal post-operative therapeutic dose for me for moderate pain, if you gave me 7 milligrams of morphine all at once while I'm on a volatile agent, I won't breathe for about 30 minutes, typically. So that means you have to give morphine minimum 45 to 60 minutes before the end of the case, the full dose. So you give me 7 to 10 milligrams of morphine here. You wouldn't touch the Remy. Now, if my blood pressure plummets, well, then you can back off the Remy. If it goes down a little bit, you just treat the blood pressure. Don't change anything. Keep everything the same, everything the same. Wait till the 10-minute mark, they're beginning to close. You shut off the Remy, and lo and behold, I'll be able to breathe because enough time has elapsed. Right from the initial onslaught of morphine's plasma levels gone up, I get no drive to breathe for about 20 to 30 minutes. And then I can begin to breathe with that amount of morphine. Okay? Dilaudid, I have to move it back even further, another 15 to 20 minutes. Right? So you're seeing like everything ends here. You are best served, especially with morphine and Dilaudid, to give it earlier. Rather than, you don't get points for like landing on a postage stamp. Right? Give it earlier, and you'll be fine at the end. So the other way, conversely. Let's say they're going, all right, we're done. We're closing, and it's like a little decision like this. What 2 drugs can you not use as an option? You cannot, right? Or I would say the other way, you can, we'll just be waking up here. Does that make sense? Okay, it's not possible. You can shut off the Remy all you want. I will not breathe, because you have to give the full dose. If you wait till I breathe, I will be experiencing so much pain that the 7 milligrams that should have worked will not work. It'll take 15. And then I'll be active. Then you'll be back to me and say, well, should we really breathe for him? Should we let him go? Yeah, it's your time. Right? Does that make sense? I know it's an advanced concept. I just want to kind of introduce you to it. You're not going to be, I don't think Dr. Schaub is testing you extensively on this. Mainly understanding the U1, U2, some fault. We'll give you some case examples maybe that are like examples of appropriate and inappropriate doses for the normal drugs, right? Fentanyl or Dilaudid. Okay, yes?
So all these times that you've given us, we give them the post-op dose, right?
Yes. You're trying to imagine when you're dosing intraoperatively for post-op, the one you really need to be concerned with is the post-operative dose range. Does that make sense? And you just got to be close. We're looking for mistakes like when you forget the decimal point. That's a no-win. Right? 10 milligrams of Dilaudid, it's not going to work well for post-op. Maybe too well. Okay? Questions? That's all I have. Oh, what would you use Remy for? The green case just uses for would be like Craney. They want to do a full wide awake neuro exam at the end. Spine cases where they prohibit you from using muscle relaxant. So if they're using motor potential monitoring, sometimes they're in pins. You cannot move, you can't cough, you can't butt. The only way to guarantee they don't do that is with a profound amount of analgesia and a good amount of hypnosis. Right? You can do Supenta or Remy. If you want to, you can either one. It's fine to use. Okay, and then the direct laryngoscopy with the OMFS. All right, cost. Some people say they don't want to use it because remifentanil is so expensive. It's $32 per 2 milligram vial. In the larger scheme of things, that's not terribly expensive. So if you're doing an 8-hour case, probably not the best choice. If you're doing a 4-hour case or so, it's perfectly fine.
So it's more expensive than that.
Yeah. Okay.
Another question.
Yes.
In our book, whenever it was talking about analgesia, it talked about like switching somebody over from PO to IV. So like if you had a chronic pain patient who's coming in to have their
Right.
back surgery or whatever, how you would switch them over. And it talks about reducing a 24-hour total by 25% to account for incomplete cross tolerance. Can you explain that?
No. Actually, to explain it intelligently, like I know parts of that, but let me read up on that and then we'll get back to it.
Okay.
I'd rather not just make part of it up because I think I know what it is. So
Is that something that you run into often, like where you have to figure that out?
So where that does apply is when we have acute pain service patients that are being treated outside the hospital, they come in for treatment. Pretend they're going to have their pain pump swapped out and replaced. They do have to. They're usually on such massive amounts of spinally injected or epidurally deposited narcotics that it's unsafe. The amount of narcotic we would have to give them just for anesthesia would be insane. Not safe. They have to stay for like 48 hours to clear all the drug away from them. So that's where you will see it. From a management standpoint, if you're doing cases during the day, that should have already been addressed by the pain service already. Your responsibility is to make sure, like you see that they're members of the pain service, you want to see documentation that it was addressed. And if not, if it got missed, that's the one we say, okay, hang on a second. Maybe not today. It's elective, maybe not today. Maybe you need to wait till tomorrow. So that can be. But you don't have to be the architect of making sure that they do that. You just have to raise awareness to it, to like the managing provider, who's usually an acute pain, doc that's doing it, or CRNA, or since doing it.
At Mayo, our pain service is anesthesia.
Right, very common for that to be. So, but they're usually not the ones also doing the anesthetic.
Right.
Right.
They're not
So
the
it's externally managed. Your job as in the typical role of a CRNA would be to see that, look for the note that says plan is to do this, and then you just verify that it happened. And then if not, all right, so then the plan didn't go optimally. If it's an elective case, then we can reschedule. If it's an emergent case, that's the other scenario. They come in the street, and you have some documentation from who they were a frequent flyer, and you know that they were before. That might just tell you that we're going to have to give ungodly amounts of opioids, and this is not the patient that we're going to wake up and extubate and then send back to the floor. Maybe they need to be watched in a step-down unit, or maybe in the ICU. That's like when we try to teach you all the full gamut of the different treatment modalities and the different types of interventions. We're trying to teach you to just be aware, more aware than most, of how to identify the cases that can't be treated the same way, so that we protect them from slipping through the cracks. Okay. Other questions? Did I get everybody's? Sorry, I think I went a little long. No one's standing outside, so yes.
Can you post it?
This one I will post, and I'm pretty sure I posted the one before we started. So I'll give that to you. All right. You're welcome. When do we meet again?
So that's that.
I'll move it up early. Too soon? Never too soon.
I mean, we missed you.
Yeah, I don't know how that just slipped through the cracks.
When are we meeting this afternoon?
I will go earlier if we can.